Hello, everyone. Welcome to year two, week two. Uh, those of you that are in the second year now and the fourth of the five semesters that we've got together. Uh, Together, we did a pretty extensive review yesterday on laboratory values as well as chest X-ray. I'll try to be brief today because I know you had several hours of this yesterday while we were in class, but nonetheless, want to just reiterate the things that we covered. So we did go over laboratory values to include arterial blood gases. Remember, your normal ranges for blood gas seven, or your pH is 7.35 to 7.45, your PaCO2 35 to 45 millimeters mercury, your PaO2 80 to 100 millimeters mercury, and your bicarb 22 to 26 milligram equivalent per liter. And then you guys remember how blood gases work, how to look for respiratory acidosis or respiratory alkalosis or metabolic acidosis and metabolic alkalosis, how um, compensation occurs, depending upon what the issue is. So this is not specific to go over that. I'll have a video later that goes over arterial blood gas interpretation and how to work on that. But we did cover things such as platelets, coagulation cascade, the intrinsic pathways, the extrinsic pathway. Talked about complete blood count or CBC, how platelets, the high and low. So those are things that we need to go ahead and begin to commit to memory as the normal values for those items, such as your red blood cell counts. That way you can determine if there's polycythemia or not, or if there's a uh, issue of platelets, we can look to see, as far as thrombocytopenia, anything of that nature, if they're too low, because those are some things that we should be checking to see if, we might be performing an arterial stitch. There's indications and contraindications for the things that we're doing. So those are things that we've gone over yesterday. Hemoglobin values, the differences between those values between male patients, female patients, and so on. So those are definitely things that we covered. Make sure that you begin reviewing the electrolyte plans that you're looking at, potassium, sodium, things of the like, chloride levels, lactate levels. Are we also associated yesterday with some certain disease processes, what you may see as far as our diet values and stuff are concerned. We also did some radiology review, whether something's radiopaque, if it's radiolucent, if it's radiopaque, it shows up some various shade of gray. Joked around, so maybe not quite 50 shades of gray, but nonetheless, so you can see here on the screen that I'm sharing with you all, there are various shades of gray and or white radiopaque that shows up. The darker areas are your air-filled spaces or air that's just showing it, and those are radiolucent. They show up quite a bit darker. You definitely want to be able to pick out your anatomical structures such as the heart, the lungs, the trachea, where the trachea bifurcates into your left and right main stem bronchus, where you get the level of the carotid. You should be able to pick up the clavicles to see if there's any rotation on the film. Also to see if the film is oriented appropriately, be able to pick out where the diaphragm is. You can also be able to see caustic angles, hopefully a gastric air bubble, if it's visible in the X-ray. Remember, we also talked about whether a film can be overexposed or underexposed, between the anterior posterior film, the posterior anterior film, which of those is superior if you happen to have fluid, uh, such as a pleural effusion, which is the preferred film for that. Remember, that's the lateral diffuse film on the given side. For that, you can also look for meniscus sign and covered things such as curly B lines, curly A lines, bat wing appearance, butterfly appearance, ground glass appearance. Those are things that you need to be familiar with, because those are some terms that may show up on our board exam when we go to take that TMC, because this group will be taking the TMC and the CSC, while the new group for the first 2 weeks will be challenging the brand new RC exam, the respiratory therapy exam, or the RTE exam. Uh, so, right quickly, just we won't spend a massive amount of time on these x-rays because we did that yesterday in class, but there's a handful of them to review. Should be able to pick out the trachea. Um, Remember, the trachea should be midline. You've got pathology that push the trachea away from the affected side or pull it toward the affected side. So essentially pushing away from the disease or problem, or pulling it to the disease or problem. Typically, masses, free air, fluid, whether it's an pneumothorax, an effusion, anything like a lot of that stuff will tend to push away from the affected side, as opposed to atelectasis, consolidation, pneumonias, things like that will tend to pull the trachea to the affected side. So our lungs should be well aerated. So if you look here, you'll see that there are increase in consolidation alex, you've got an increase in radio opaqueness on the right side. So looking at this over here, patient's right side, over here, the patient's left side is probably the opposite of what we got. So patient's left is here, patient's right is here, as opposed to my right hand, my left hand. It's just it's like a mirror image I'm standing in front of. So my right is their right, my left is their right, and vice versa. Prostophrenic angle over here is nice. You have decent vascular markings that extend out. So over here, it would likely be an increase in aortic tissue pneumonia or something that would cause them the trachea to be able to pull away or pull toward the affected side. Right over here, you can see that you've got gastric air bubble. I talked about with your clavicles. You see that you're basically a spinous process throughout. You can pick out the trachea and the carotid is here, right main stem bronchus is here, left main stem bronchus is here. We also noticed something different with this one, that you've got loss of vascular markings here to this border. And you can see that you get just an increase in radiolucency in that area. So this is a mini thorax. This is free air over the pleural space. And if you look a bit more closely, these ribs are broken. So I would doubt that those are going to contribute to the onset of the pneumothorax on this side. You see this little marker up here indicating the left side. This is left, this is right, so taking on the right side of the pneumothorax. In this situation, you got the right side over here. Heart should be an object that's a U-shaped object that tends to point where the apex of the heart points toward the patient's left. So this would be an indication of an individual that has malrotation of heart or dextrocardia. You may also see some individuals that present sinus syndrosis as well. A couple of things that we see here that we haven't seen in the past, we do have the presence of an artificial airway. So in relation to that artificial airway, typically you got a radiopaque line that runs down in the tracheal tube that should terminate 3 to 5 centimeters, for your even textbook. And you might hear 2 to 4 centimeters in the hospital, 3 to 5 centimeters, what you'll find in the even textbook, and 3 to 5 centimeters, typically the landmark that the NDRC utilized for a reference point for tip of any tracheal tube above the level of the prime. And the prime is where the trachea splits into the right main stem and left main stem bronchus. So that tube is sitting in an opaque view. I don't have a ruler to be able to measure that. Right at the area of the clavicles, you might could advance it a centimeter or two, but nonetheless, both lungs are being ventilated. Remember, if you go too deep within the tracheal tube based on anatomy, you're going to be in the right main stem bronchus 9 times out of 10 if you insert that tube too deeply. So this is an intubated patient receiving mechanical ventilation. You can see the pilot balloon up here. That's where you insert your syringe and apply air down into the cuff within the tracheal tube. You've got lead wires showing that we haven't seen before on a different X-ray. And now we've also got the presence of what appears to be a central lung. That central lung, you stop there around the right atrium of the heart. If you were to be able to follow and trace that all the way up through the right ventricle and up into the pulmonary artery, then you'd be looking at a pulmonary artery catheter, and the main brain of that would be the Schwann-Vance catheter that you might read about. But for testing purposes, we're going to look at that as a balloon tip flow directed catheter. It might say pulmonary artery catheter, but the test would tend to steer away from main brand names or proprietary names rather, and they may refer to it as a balloon tip flow directed catheter. So just like we were talking about with that pulmonary artery catheter, balloon tip flow directed catheter, you can now see this one enters through the right atrium, goes through the right ventricle, and then up the pulmonary artery, or through the pulmonary, signaling it out and into the pulmonary artery. That would be so you can get your wedge position off of that as well if you do further invasive hemodynamic monitor. There are also some sternal wires that we see here. So I'm assuming that this individual had a coronary artery bypass graft surgery. The chest has been open. This patient is also intubated. You've got the radiopaque line on the carina there. Again, that's around the level of the clavicles. Might go in a little bit, but both on the airways, so we assume those are okay. Computer tomography, we did talk a little bit about computer tomography yesterday, because ultimately we got a patient that would lie down. This provides a slice of the body. And this is the wrong images here. So you might look at a chest CT, abdominal CT, PET CT if we've got a patient that's suspected of having hemorrhagic stroke or, brain bleed or anything of that nature. Scoliosis, work with individuals we talked about with different obstructive and restrictive disorders, how this might bring about more of a restrictive issue with our patients and how it might be extremely difficult to ventilate those individuals. And then we wrapped up with essentially what a normal looking chest X-ray would look like. So being able to identify those prostaglandinic angles with gastric air bubble, outline the heart, find the firm, where they split the hilar region, and the hilar region is going to be the blood vessels and airways enter into the lung. Clavicles don't demonstrate significant amount of rotation in this individual. Uh, uh, don't be confused by the scapular border that you might find that can provide a distinct line. You want to make sure that there's vascular muscle can extend all the way out to the chest wall, and you should be able to see those spines processes as you move down. And what I don't have shown as an illustration we did talk about yesterday was between epiglottitis and croup. Epiglottitis will give you that thumb sign on the lateral neck X-ray, and typically you're going to get those individuals to an OR intubate them relatively quickly so you can protect the airway so that it doesn't essentially close off and it becomes extremely difficult or impossible for them to breathe. And then you have those individuals that may present with the church sleeping sign or the fence picket sign with their trachea, with that taper of the trachea toward the top, and that would be indicative of croup. And those kids have their presentation as well as going on with the barking call. So that's pretty much a real rough and quick overview of what we did in the second week of our year 2 class. And next week, I believe we'll be moving on to ventilator graphics. So we covered PFTs first week, chest X-rays, laboratory values, second week, and then next week we'll be transitioning over to ventilator graphics and more to come on that in the future. Thank you all for your time and attention. I hope you have a good day.